Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the area of advanced illness, specifically those that would qualify for either palliative care or hospice care. Those are two separate services. I'm also a certified end-of-life doula and end-of-life educator. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Shouldn't we be prepared for what we're all going to face? Studies have shown that if we plan, and we're not talking suicide when we mention planning, but if we plan for how we want to die and make sure that our wishes are well documented in writing, aka a living will, and we let our family and our friends and those who are involved in our lives know of our wishes, we're more likely to have a good death than somebody who, let's not talk about it. Let's ignore the subject matter. So if these are topics of interest to you, because I'll have videos for my fellow hospice nurses, my fellow holistic nurses, end-of-life doulas, and other end-of-life professionals, as well as caregivers and family members, please consider subscribing and hitting the bell notification below. And please like the video, as it does help small YouTube channels like mine. The topic for today's video is going to be one that came up as I'm taking my advanced life planning course through the International Life Movement with Pam Carter. And it just, wow, there's a lot of research articles out there that dialysis is a type of artificial life and support. So we talk about pulling the plug. It's not just the ventilator, it's not just intubation. And when I went to dig deep on this issue, while there was a lot of peer-reviewed articles on the nemesis, so to speak, there wasn't a clear discussion of what this impact means. So I wrote an article on this subject matter, and I want to discuss that with you today. Before we go on to the topic for today's video, I want to ask you, what are you grateful for? Feel free to comment below. It's a non-judgmental channel, but if that's uncomfortable for you, keep it up here. What are you grateful for? In my experience in life, if you live a life of gratitude, forgiveness, and faith, you build resilience. So when storms happen in your life, you're less likely to be slammed to the floor, and if you are, you spend less time there. You're less likely to suffer from depression. You're less likely to go to negative thoughts and stay there for long. What are you grateful for? So what I'm grateful for is I'm grateful for each and every one of you that take time out of your day to watch my videos, those who like, those who subscribe, those who read my books, those who write encouraging words, whether it be on the videos or Facebook or LinkedIn. I just love hearing feedback from people. Oh, I bought this book or I read that article. It helped me with whatever the case may be. I'm grateful for that. And so let's get into the article. And so, by the way, this is using Lovart, Lovart, uh, AI to generate the images, as well as Canva. And so I'm going to leave a link in the description below for the article. Yes, I do write very thorough articles. I will try to keep this video short and to the point. But one of the first things I want to bring out for my viewers, my listeners, is dialysis is not a requirement. For every medical treatment, every medication, every procedure, you have a choice. And sadly, more often in America than in other countries, we're often told the doctors know best, and they are educated and they're very experienced. The doctors know best. Follow whatever the doctor has to say. The problem lies within two components. One is that while doctors take an oath, first do no harm, the main goal for doctors is, like our healthcare system in a way, is rescue at all cost. Rescue no matter the amount of suffering. Rescue no matter how much damage it does to your body, to your lifestyle, to your dreams. Rescue at all cost. And when rescue cannot be achieved, they maintain with the potential for hope. And the caveat is very rarely do they go over the cost of maintenance and the reality of what hope you're looking at. They very rarely have those extremely difficult discussions about a medical procedure, a medication, or any other type of treatment. Most doctors don't like to fail. So they don't explore, this is the second thing, they don't explore the alternatives. Because sometimes what they represent as being the intended cure is worse from a suffering point, worse from a quality of life point than the alternative. Whenever you have a doctor, nurse practitioner, a healthcare provider tell you, here's the course to take, like here's a prescription for a pill or a tablet or a liquid or a cream or an injectable product, a surgery, dialysis that we're going to be moving into because this is part of it, you should be asking questions as to, for medications and treatment, what's the absolute risk reduction percentage? That's the percentage of benefit. Most medications and treatments, including injectable products, have been studied well enough to know what the absolute risk reduction percentage is. It is a percentage. So to give you an example, and this is going to be a tight rabbit trail, but to give you an example, when a doctor says, you have high cholesterol, and just so you know, there's two theories on heart failure. One theory is high cholesterol. There's another theory out there. They're both theories. They're not proven. They're theories. So they give you, I'm going to prescribe a statin. Now that could be a torvastatin, simvastatin, pravastatin, rovastatin, whatever it ends with statin, S-T-A-T-I-N. The absolute risk reduction for every statin known to mankind is 0.8%. So 0.8% reduction in absolute mortality, 0.8% in reduction for having a heart attack. Think about that. Less than 1% benefit, and most of these drugs have huge copays. And on top of that, what they don't go over is side effects are when, not if. Side effects are when, not if. So getting back to statins, side effects of cognitive impairment that can lead to mild cognitive impairment, MCI, that can lead to dementia. Side effects of increasing blood sugars that could lead to pre-diabetes, that could lead to worsening diabetes, that could lead you with brittle diabetes, the worst four. Now that's still part type 1. We're not talking type 1, type 2. Both types could have brittle diabetes. It could also deal with muscle aches and pains to the point where you can't walk anymore, all for 0.8% benefit. That's the problem with healthcare in America today. And it's no different when we get to dialysis. So here, there's a choice. Dialysis is a type of artificial life support. It should be treated as being no different than intubation and being on a ventilator and thinking pulling the plug. Now the difference, though, people are going to argue, but I could speak, I could talk, I could still get around. but this is part of it. I'm hoping that you do read the article because I am going to try to keep this video short. But the issue is that you spend how many hours in a chair where you can't get up and move around. You're tied, plugged in, and it's such an exhausting procedure that you spend the next day recovering, only to go back again to the same chair. May not be the exact same, like ABC, pick a chair, but it's the same thing day in, day out. Chair recovery. And if you don't need it every other day, the weekend you get a break. Typically it's Monday, Wednesday, Friday, or it might be Tuesday, Thursday, Saturday. So you might have an occasion where you have 2 days break, and wow, that gives you a day to live. That's what you're really facing in terms of quality in life. So the reality, because dialysis, let's look at what dialysis is supposed to be for. It's supposed to be a bridge to a kidney transplant, not dialysis for life, a bridge to a kidney transplant. Well, there's over 90,000 Americans waiting for a kidney transplant at any one point in time. Now, that's an approximate number. Each year, and it varies, some years it might be 20,000, others years 23. One year, I think, was a high of 27,000. People get a kidney transplant in the United States each year. What does that mean for the other 60, 70,000 that didn't get the transplant? 80,000 in low years. Well, they go on. So the average wait time is 3 to 5 years, but that's not guaranteed. And many patients wait much longer. I've been a nurse for enough time that I deal with this where the CKD5, end-stage renal disease, I've been on a kidney transplant list and it's been 7 years and they just get tired enough, I can't take it anymore. Or they get to the point where dialysis, because it's meant to be temporary, the bridge isn't even working anymore. There was a case just this past week in the hospice and end-of-life group on Facebook where they're sending the loved one home from dialysis. Their blood pressure got dangerously low, and the dialysis center is finally admitting defeat. You should think of hospice. And part of the problem with this is that was, and I don't want to use the word lucky, but for lack of better words, that was a rare case because most of the providers at these dialysis centers, the nurses and the doctors, do not talk about that this is a temporary bridge. They don't talk about the suffering that they're witnessing. They don't talk about the close calls. They don't have these conversations because they don't want to admit defeat. They don't want to admit failure. They don't want to talk about, well, gee, hospice is a very valid alternative, and you're already, we're all dying to begin with. So the article goes into the suffering, and you do have a choice. You have a choice before they even put in the fistula. You have a choice. So the article does go into chronic kidney disease. I'm going to be going through, I'm going to give a link in the description below. But part of the solution that I have in the article, and it's not just hospice, hospice is a very, very valid choice. But I would encourage any of you, if you're facing this yourself, let's say you got a diagnosis that you have chronic kidney disease, stage 1 or 2, stage 1 or 2, or 3, find a properly trained end-of-life doula, preferably that lives near you. I could do this remotely, but it's actually better if they live nearby and can see you in person. Because if you connect with them, even though this is where I sometimes I wonder when people came up with names for services and career paths that they would really reflect, because an end-of-life doula is not just for end of life. Part of the reason I refer to myself, I'm not sure how quickly that's going to, there we go, as a life transition support guide is I'm there for the entire journey. 18 and well, not just they're dying, 18 and well, And so by getting an end-of-life doula that's properly trained, we can work on illness navigation. What changes in your life can you make today or tomorrow, this week, this month, next month? Don't want to go too far out to push this off, to push it further away. There are countless cases of people who made lifestyle changes that they pushed the decision on do they do dialysis versus hospice off for years because they sought help in navigating kidney disease. And yes, you could do this with your doctor and healthcare provider that will spend 15 to 30 minutes with you here and there, or you can get a properly trained end-of-life doula that is not, yes, it's private pay, but we're not bound by insurance guidelines for how long we spend with the person. So this article goes into life, that it is a form of life support, the false promise of buying time, and again gets into the recovery time and so on. The cost is beyond. I'm glad that I did this article. Jackie from my cohort and Miriam and another of other people that's taking the advanced life planning class that I am. I think it's cohort 11 or 12. I'd have to double check for this one. It's like, gee, we're finding information out there on feeding tubes. I have them on compassioncrossing.info. IV hydration, I have one in compassioncrossing.info, but not on dialysis. And I'm like, you know what? Let me write this because I didn't know the fact. 5-year survival rate's 35%. I have a relatively new friend in Kentucky that just lost a loved one who had chronic kidney disease with heart failure. And they were dealing with this where the spouse wanted them to continue, there's hope. And the person that had chronic kidney disease was suffering. And that's something that we have to have discussions on. So let me find here the medical culture I mentioned about doing everything. There's financial incentives. Um, this is huge. There have been a number of news articles over the year um, on the revenue. It's mainly your chronic illness. Let's make money out of it. Give me one moment here. Trying to find. Sorry for this. Again, these are unscripted. Okay. When you get into living wills, and this is another area that a properly trained end-of-life doula, like myself, and IDLM, the International Life Movement, has an excellent training program for how to write very complete, very thorough living wills to ensure your wishes are honored. So there's a way as you're writing your living will that you could use specific language to include in the directive. Clear choices whether you want it or not. And whether you'd want to try peritoneal dialysis versus hemodialysis. Hemodialysis is what most people are aware of. So if you hear the word dialysis, the overwhelming majority of the time it's hemodialysis. That's where it's connected here. Granted, you can get a temporary device as well, but peritoneal is typically dialysis at home where there is a connection in your abdominal area, but still lots of time, still lots of risk because if you're doing it at home, it's just you and your family. You're not even at a facility testing. But in this article, it gives what language you could be using in your living will. And while you can do a living will on your own, You can. Some people, like I can't afford an end-of-life doula. It's significantly less expensive than an attorney. You want to try to do it yourself. Be careful if you go that route, because if you miss something, your family will pay the price. You might not have to, but your family will, or you will from a suffering standpoint. You can put in your document, like if you start dialysis, how long you want to give it. A lot of reason to put this in writing is so that if something happens where maybe you have a stroke and you can't make the decision anymore, you want your surrogate to know very clearly and explicitly what your wishes are. In writing takes away the doubt, the importance, and then here also for your proxy. If you have this trial period, you want regular family meetings. So this is very critical. I want to come to the landing zone here because the article is going to be available for you to read. But couple things. One, whenever you go to a doctor appointment, you should be asking quality of life impact. Should be asking quality of life impact. I still remember from a couple weeks ago, a fellow end of life doula reached out to me, and I don't mind these. I love the brainstorming. I believe it is collaboration. We don't compete, we collaborate. She came to me and said, I had an 83-year-old heart failure patient that has AFib, and ablation wasn't an option. What should be your questions at the doctor visit? And she came to me mainly because I'm a nurse and wanted to know the medical. But between you and me and to her, I didn't go down that route because to me it's quality of life. And you don't need a nursing background to ask quality of life. So I said, what does this person want to do over the next 1 to 2 years? What's on their bucket list for those 1 to 2 years, so that when you're in a doctor visit, number one, getting back to asking about quality of life impact, this is what I hope to do over the next several years. If I take this, what's going to be my impact? There should also be a question when it comes to any pill, tablet, liquid, injectable, stick a needle, injectable product. What is the absolute risk reduction percentage? If they don't know, they need to look it up and get you that information. You have a right to that information as informed consent. You have a right to know what the absolute risk reduction percentage is. And unless it's experimental treatment, it exists. It exists for vaccines. It exists for statins, your all your different heart medications, the anticoagulants and so on. It exists. So ask for it. Then ask, what are the side effects, including the adverse reactions? And then, what are the alternatives to this? What are the alternatives to this? So for cholesterol, for example, there's berberine. And you gotta give the fine print. I'm not giving medical advice. This is for educational purposes only. But there's berberine, which you have to do your own homework on, because you just don't buy the. I had a friend. I got the highest dose of it all. IV, research, homework, your own homework. I'm not telling you what to take in terms of take this many milligram, blah blah blah. I'm not your doctor. I'm not your healthcare provider, but there are alternatives, including lifestyle changes. And again, keep in mind, high cholesterol is a theory, not a scientific fact. What are your options? When it comes to kidney disease, what you get the first CKD stage 1, 2, 3. What lifestyle changes could I be making to avoid stages 4 and 5? And seek out an end-of-life doula that is properly trained. Question them, query them, check their references. Most likely, if they came from the International Doula Life Movement or INELDA, or I use NIDA. I'm finding out more and more NIDA is both good and bad. The good is they're the only independent agency out there for end-of-life doulas. The bad part is there's pros and cons for the proficiency badge, because you could take that badge without schooling, which is could be a good thing for those who want the badge, but that doesn't mean that they're adequately trained. I'm not saying don't give them a chance. Everybody needs to get out there and have an opportunity, but depending on your case, how thoroughly they are. And I know for the International Dual Life Movement, there it's unbelievable thorough training that is constantly kept up to date. And they were the first school to require continuing education in order to maintain certification. Now other schools are playing mimic. And Indelda as well is a good school out there. And yes, there are others, but that's its own landmine in an unregulated industry. But make a connection with an end-of-life doula that could walk you through those lifestyle changes and help you be accountable to those lifestyle changes and help you to have a complete living will that takes into account, do you want dialysis or not? Are you willing to give it a try for how long? And the more thorough you dive into these deep discussions, the better quality of life you're most likely to live, because it doesn't happen by chance. It doesn't happen by rolling the dice. It doesn't happen spontaneously. It happens through digging deep and discussing it and going over with it. I thank you for your time. Take care, and God